Good morning, class. Welcome to Nursing 515. This week we're going to be covering neurological deficits. Today specifically we're going to be covering ischemic strokes in our lecture. I have this PowerPoint, I had it posted on Blackboard, so I hope that you've printed off the slides so you can follow along and write notes. If you'd like me to stop at any point along the way and repeat something, or if you have a question, feel free to stop me. Also, I just wanted to let you know we have already covered the anatomy and physiology for that, so we're not going to review that again in this lecture. We're just going to go straight into the deficits. Now, strokes are definitely something you're going to see in your rotations in the ICU. This makes up a large portion of our population in this unit. So let's move on, talk about our learning objectives. Number one, we're going to define what is an ischemic stroke. 2, we're going to outline the medical treatments of an ischemic stroke. This does differ from a hemorrhagic stroke. We're going to discuss a nursing care plan of a stroke, a client with an ischemic stroke. This will be ongoing throughout the presentation. At different points, we'll talk about what the nursing care plan would look like, but also we'll put it together. And finally, we'll perform the AHA NIH stroke scale assessment. We're just going to touch on this so that you have a background of what it is, kind of an overview, and then our simulation lab, we're going to go into detail about what that is and what that assessment looks like. It is a very detailed, thorough process. So moving on, I believe this jumped ahead on me. So what is a stroke? A stroke is the sudden onset of an acute neurological deficit persisting for more than 24 hours and caused by the interruption of blood flow to the brain. The key right here is more than 24 hours because we'll talk about later TIAs that don't last this long. So as a review, normal consciousness requires a wakefulness, which is mental and intellectual cognition, plus affect or mood, and arousal. So alterations in any of these categories substantiate a neurological deficit. Just to point out, there are many other diagnoses that could also affect the neurological status. Can anyone give me an example of something or a situation where a patient's neurological cognition would be affected? Okay, I'll give you one. Hypoglycemia. If you have a patient that's hypoglycemic, they're going to have sudden mood change, nervousness, they're going to have unexplained fatigue and a headache. These symptoms could be found along with a patient or a client that has a stroke, but this patient has hypoglycemia. So it's important to do the initial background, the history, the initial assessment are all very important in determining what's actually going on with your client. So a stroke, there are common neurological symptoms that are found in ischemic stroke. So yes, there are neurological changes, but these 3 things are commonly found. And that is hemiparesis, which is hemi meaning hemisphere, which side, and paresis is paralysis. So there's slight paralysis or weakness affecting one side of the body. And it's opposite of where the attack is in the brain. So if you have a right-sided stroke, the left side of the body is going to be affected, and vice versa. So it's a weakness on one side. Also, there is aphasia. That is a common symptom with strokes. This is a condition characterized by either partial or total loss of the ability to communicate verbally or using written words. A person with aphasia may have difficulty speaking, reading, writing, or recognizing the name of objects or understanding what other people have said. So this is one of the most difficult things of a stroke because you have a patient and neurologically, in their mind, everything is normal. They can understand, but they can't get the words out. Or maybe they cannot understand it, but they seem normal on the outside. So strokes it's very difficult to watch. But this is a common sign that we see with strokes. Another is the vision. Sometimes you get a loss of vision in one half of the visual fields or in both eyes. So just as background, does this thing keep jumping on me? Sorry about that. Oh no, we're good, sorry. Stroke is a 3rd leading cause of death in the United States. It's preceded only by heart disease and cancer. And strokes are classified as ischemic or hemorrhagic. Oh, we're almost ready to go on. But ischemic is 87% of strokes and hemorrhagic is 13%. So more than likely when a patient walks in or when they're brought in by ambulance with a stroke, more than likely it's ischemic, but there are the cases of hemorrhagic, and this is important in determining the next steps. So moving on, etiology and risk factors. Ischemic stroke results from a reduction or blockage of blood flow to the brain. And that reduction in blood flow can be caused by an occlusion. That can be divided up into a thrombic event or an embolic. A thrombic event means it forms in the brain. So the vessels in the brain are usually it's atherosclerosis. So the plaque buildup and it's narrow, and eventually no blood's getting through. And then you get ischemia to that area. The other kind is an embolic event, and that means a clot is formed elsewhere in the body. It travels through and then it lodges in the brain vessels. So usually this is caused by I won't say usually, it's 30% of the time it's a cardioembolic phenomenon. And most of those cases are caused by atrial fibrillation, which is also a risk factor that we'll talk about. So risk factors for developing ischemic stroke. Number one, the greatest risk factor for developing ischemic stroke is hypertension, just blood pressure that the client is not keeping in control. It's very important to do teaching with your clients about blood pressure control and taking their medications even if they feel good, to do monitoring. Blood pressure that's too high, they're at very high risk of developing a stroke, hemorrhagic or ischemic. Number two risk factor for an ischemic stroke is atrial fibrillation. As we talked about before, it's high risk because clots form in that blood that's pooling in the atria, because the atria are just quivering. And so it's high risk of developing clots in these, and then if the clot gets formed and pumped through, it goes right to the brain and you get an ischemic stroke. So patient education here, very important. Take their medication, the antiarrhythmic or the antiplatelet, or both. Number three is dyslipidemia. This is you can have narrowing of the arteries from atherosclerosis, and that is a risk factor for having ischemic stroke. Patient education here, importance of exercise, healthy diet, medication to lower cholesterol if they can't keep it below 200 on those other items. Also, number four is diabetes. Diabetes can cause accelerated atherosclerosis, including cardiovascular disease and stroke. Patient education is important here, just controlling their blood sugar, checking their blood sugar, taking their medication as ordered, eating right. So a lot of it's healthy diet and exercise. But studies have shown a decrease in cerebrovascular events in those clients that keep their hemoglobin A1C under 6.5%, so that long-term control. Smoking, this constricts the vessels, so this is a risk factor for ischemic stroke. So patient education here, stop smoking. We might have to get the healthcare team involved. Maybe they need counseling or medication or support groups, but it's very important. There are other risk factors, but these are the most common risk factors for ischemic stroke. So pathophysiology. Reduced blood flow means you're going to have an ischemic injury. When a blockage, whether it's local forming in the brain or whether it came from somewhere else as an embolic event, it decreases blood flow to a level insufficient to maintain adequate oxygenation to a portion of the brain. So therefore ischemia results. Has anyone ever heard the word penumbra? It's a strange sounding word, but as you can see in this picture, so there's the dead tissue right here, but this area around it, the penumbra, this is tissue at risk, and this is salvageable tissue. It's just important to get blood return back to that area. So yes, it can be salvageable with return of blood flow. However, sustained anoxia leads to apoptosis and cellular death, and that cannot be salvaged. A lot of times you'll hear a stroke called a brain attack. This is just comparing it very similar to a heart attack where there's an infarction on part of the heart. Well, that's basically what's happening in the brain, so it's like a brain attack. TIAs. TIAs are transient ischemic attacks that mimic a stroke, but they last less than 24 hours. Remember, in the definition of stroke as neurological deficits, it lasts more than 24 hours. TIAs are less than that, and sometimes they can last only 10 minutes. But these are a warning sign that should not be ignored. This is a warning that a stroke could occur very soon, and so changes need to happen to ensure that strokes do not happen. Some complications from ischemic stroke is cerebral edema, and this results from a loss of normal metabolic function. This actually does not peak until day 3 or 5 after the stroke, which means they're still at risk of having increased pressure in the brain, and it is a common cause of death the first week after stroke. So very important to do monitoring of your patient, keep an eye on them, and also with patient education if they happen to go home before that point. But usually if it's a big stroke, they'll stay inpatient throughout that first week. Hemorrhagic conversion. This can happen at the site of the stroke lesion, where the site of clot then starts to bleed, causing a hemorrhagic stroke. It's said it could happen because of the pressure of the blood in the vessel that's already weakened, which causes it to rupture and bleed. But it's definitely could happen. So moving on, assessment, the NIH stroke scale. And this is why I said we'll touch on this a little bit, but we're really going to dive in deep when we get into our simulation lab. So this stands for the National Institute of Neurological Disorders and Stroke Scale. So as it says, it's national. It is a recognized score that across the country where we can put a number on the neurological examination and how well the patient is doing after a stroke. It's a 15-item neurological examination used to evaluate and affect acute cerebral infarction on 9 different levels. And they test level of consciousness, language, neglect, visual field loss, extraocular eye movements, motor strength, ataxia, dysarthria, and sensory loss. It's a systematic assessment tool that provides a quantitative measure of stroke-related neurological deficit. So the score is 0 to 42. The higher the number, the more of a neurological deficit the patient has. And the worse off they are at that point. So this assessment is usually done baseline, 2 hours after any treatment, 24 hours after the onset of symptoms, 7 to 10 days after the stroke, and then again at 3 months. So it's, puts a number on it that we can see how they're progressing or degressing. Diagnosis. So a client comes into the hospital. We're pretty sure they're having a stroke. Maybe they have left-sided weakness. We have got to figure out, is this ischemic or is this a hemorrhagic stroke? So we need to know what to do next. So number 1, we have got to get them into the CT scanner, a non-contrast CT scan. The goal is to have this completed within 1 hour of arrival to the hospital and read. So the reason we go to the CT scan is not because we're going to see ischemia, because ischemia actually does not show up on a CT scan for 12 to 24 hours. What we're looking for is to rule out an intracranial hemorrhage. So we would see a bleed on the CT scan. But if it's obvious they're having a stroke, and then we don't see a bleed, we know they're having an ischemic stroke. Confirmation of diagnosis of ischemic stroke is a first step in emergency evaluation of these patients because treatments differ significantly. And we'll dive into that with the next slide, I believe, yes. So also with diagnosis, we're going to do an EKG. This is required because there is such a correlation between cerebrovascular disease and cardiovascular disease. So we're just going to check the heart out. And also we're going to do some lab work, which we won't go into right now. Okay, so medical management. TPA, alteplase, is the drug of choice for an ischemic stroke. And it's very specific on who can get it and who cannot get it, but ideally this can change a client's world. If they are completely flaccid on one side of their body and they meet the parameters and they get it, they can get all of that movement back. I've seen this time and time again, and it's really is a miracle. Indications to getting TPA: 1, you have to have a diagnosis of ischemic stroke. 2, it must be given within 3 hours of the onset of stroke symptoms, and it could be up to 4.5 hours according to the AHA. Also, the client must be over the age of 18. Contraindications. Can anyone think of why a client should not get TPA, which is a clot-busting medication? So some of them are a sustained hypertension despite medical intervention to lower it. So we can start them on usually it's a drip, maybe cardine, to bring their blood pressure down. But if we cannot get that blood pressure down despite medical intervention, they're not going to be getting TPA. And the goal is to get the systolic below 185. If they had a seizure at onset, they will not be getting TPA. Also, a recent surgery or trauma less than 15 days old, or a recent intracranial or spinal surgery, head trauma, or stroke that's less than 3 months old, or a history of intracranial hemorrhage, brain aneurysm, vascular malformation, or brain tumor, unless it's a lesion with a very low likelihood of bleeding. So those are the contraindications and indications. If they can get the TPA, it's been within 3 hours and they meet all the criteria. The dose is 0.9 milligrams per kilogram up to a maximum dose of 90 milligrams. 10% is given as an IV bolus, and the remaining 90% is given over 60 minutes. And this can be started in the ER, and then usually they come over to the ICU unit where the nurse takes over. These patients are one-on-one. There is one nurse, one patient, because the assessments are going to be very frequent. And we'll talk about that on the next slide. In addition to the TPA with the medical management, and this goes with all patients, whether they receive TPA or not for the ischemic stroke, we got to have blood pressure management. And this might seem a little opposite from what you would expect, but if the patient does not receive TPA, the doctors usually allow them to have permissible hypertension because they want that blood flow to the brain to perfuse the penumbra and perfuse that area that's not receiving the blood flow like it was from the ischemic stroke. So sometimes they let it go and they won't treat it unless systolic blood pressure is higher than 220, which seems excessively high, and they don't let this continue on, but they want to let that perfusion to the brain occur. Of course, if they've gotten TPA, the parameters are going to be lower because they do have a risk for bleeding, a higher risk for bleeding, I should say. Glucose management is another one we have because there's a correlation between hyperglycemia and worse outcomes after stroke. So we want to keep a tight control on their blood sugar. And also, clients have a risk of aspiration because of if they have decreased level of consciousness, facial weakness, cranial nerve deficits, they might have trouble maintaining their airway or swallowing. So assessment is very critical before you give them any food or drink, and also just monitoring their O2 sats and their breathing, make sure they don't need to be intubated. Also, they are a risk for DVTs and therefore a pulmonary embolism. So we want to put those elastic compression stockings on and order the SCDs and make sure they're put on. Early progression of activity, and then anticoagulants. Of course, if they get TPA, we would not give anticoagulants for the first 24 hours, but then we would start them as soon as possible after that. So for neurological assessments, we are going to be frequently doing neuroassessments on our ischemic stroke patients. And that includes GCS, a glaucoma, Glasgow Coma Scale. We're going to be checking their pupils for size and reaction to light. We're going to be checking their extraocular eye movements, motor function, sensory function, and also their vital signs. If they have received TPA, we're going to be doing a full neuroassessment every 15 minutes for 2 hours, and then every 30 minutes for 6 hours, hourly for 24 hours, and then according to hospital policy. So this is why they need to be one-on-one. It is so important to get that assessment done on time to make sure there's no digression in the patient's status. And if they do not get TPA, we're still going to be doing frequent neuro checks on them according to what the doctor orders. If they have received TPA, just a couple things to keep in mind. You're not going to be wanting to, the anticoagulants we don't give for 24 hours, but also we're going to want to delay placement of invasive tubes like NG tubes and bladder catheters and invasive lines because they are at risk for hemorrhage. So usually we hold off for 24 hours if we can, and then start those the next day if they're needed. So what I would like for you guys to do is we have talked a lot about ischemic strokes, and the assessments and the ongoing and the education. So I would like for you guys to get together in groups of 3 or 4 people and come up with some nursing diagnoses that you could use in your care plan for a stroke client that you are possibly or potentially going to be taking care of in the ICU. So take a few minutes, get together with your groups and come up with some nursing diagnoses. And then when you're done, we're going to just look over some of these care plans on the next page. Okay. So here are some possible nursing care plans that your groups may have come up with. Ineffective cerebral tissue perfusion, impaired physical mobility. You guys can take a look at all of these different care plans. I do have them each online on the web with the whole care plan written out for you. You'll need to personalize it for your particular patient, but this just gives you a guideline to work with as you're taking care of these clients in the ICU. So I hope this gives you all a good background, a good foundation to start off with ischemic strokes. I encourage you to read your chapters in the books as assigned and look over this PowerPoint when you go home today or throughout the week. As we go into hemorrhagic strokes with our next lesson, you can compare and contrast the two and how they're different in the care and assessments. And I thank you guys so much for your time. Have a great day and enjoy your clinicals and simulation lab.